But I just wanted to go over a few of mine that I did make changes, and I just want to explain why some of these others that I accepted really weren't a good choice, but I accepted them anyway. I know there was one about, we gave a picture of urticaria and angioedema, and I said out of the following, which is the most important thing to prescribe, I was looking for EpiPen. Because again, I talked about no matter whether they have difficulty breathing, and that person had some tingling in their tongue, so it just would have made me a little bit uncomfortable. That to me was primary. The other things were kind of secondary. For sure the H2 blocker. H1 blockers for sure, that's right up there, but your H2 blockers, that's kind of secondary. And the blood work secondary. I did accept the immediately DC the amoxicillin just because, yes, we want a DC. The kicker with that, though, was I said, and replace it with a cephalosporin. And there is that cross-reactivity between penicillins and cephalosporin, so that's really not a good choice to switch it to. I will accept it, but I just wanted to explain for when you're out on, you know, seeing these patients, we don't want to switch from an amoxicillin to a cephalosporin. Another one was a shave biopsy on the face of a young female. I was looking for the aluminum chloride just because of the non-staining. I'm going to go ahead and accept the ferrous sulfate, whatever. I'm not going to accept the cautery because I just, you know, usually we don't do that, and that's going to encourage more scarring, deeper scarring, and with a shave biopsy, you're never going to do a suture. You don't go, you know, you need to have better margins, wound margins, than to pull that together with a stitch. So, any questions about either one of those so far? Okay. There was one that I just gave all credit for, just because I probably didn't, I know it was in your notes, but I probably didn't emphasize it enough. And it was just kind of one of those tricky ones. I wanted to see who, you know, maybe was listening. The treatment of the warts, how I talked about there are destructive and irritating modes, such as the liquid nitrogen, the blistering agents, the salicylic acid, things like that. And then there are other methods that are trying to boost up your immune system or recruit the immune system to get the immune system to help us fight these off. So the way they work are a little bit differently. So out of those, I think I had, I can't remember, but it was the DCP, because that's the one that you're trying to stimulate that allergic response in the skin, and then again get that immune system. All the other ones, the salicylic acid, the liquid nitrogen, and I think it was the cantharone, 2 blistering agents and 1 just irritating sloughing. That makes sense? But again, because I don't know if I emphasized that enough, I accepted all 4. I think the last one I made changes to was the one with the picture on the hand. Did most people realize that was erythema multiforme? Mm-hmm. Okay. No? Okay. Okay, that's all right. I mean, and that could be why you maybe picked a different route of treatment. Erythema, I was hoping that was good enough to see those rings, the targetoid lesion. In the history I gave that there were no oral or mucocutaneous, you know, that kind of delineates EM minor from EM major, okay? And again, EM minor is large majority of the time driven by HSV. Other infections can too, but HSV is by far the most common, and I think I emphasized, even if a person doesn't have a history of cold sores, I think that's the first thing to try, is the oral acyclovir, because that happened with me. Remember that gal who came in with this rash, and the path came back as erythema multiforme, which kind of surprised me because I wasn't suspicious for that. I put her on acyclovir and it just completely disappeared. Now, I did go ahead and accept a prednisone taper, just because that certainly wouldn't hurt. I can't remember the other two options on Zyrtec. I mean, again, that's secondary, that's more for itching or things like that. Okay, what was the other one? I think it oral antibiotic or something. Okay, does that all that make sense? Reasonable?
Thank you.
Yeah, any other questions you guys had about any of the questions, at least from my part of it? Yes.
You had talked about for like when there's a lot of warts to remove. I think you had said that the candidiase, whatever, was best for that. Is it always going to be an injection? I don't think I knew it was an injection.
Candida is always an injection.
Okay. So why is that good then if there's a lot of them? You'd have to like shoot each one?
Yes, but what's nice, and again, I don't know if what's nice about that particular one, what are we talking about? Candida, thank you. Candida is, you don't have to treat every single lesion, because again, you're trying to get that immune system revved up, and once that immune system gets revved up, even if you don't treat all of them, it will attack all of them. Now, there was another injection, that bleomycin, because that's more of a destructive method, you really kind of have to inject every single one of those, and those are pretty doggone painful, but yeah, I for sure didn't want the surgery, just because, you know, I think I emphasize, I don't like to, for the most part, excise warts, especially with as many as she had. She'd have scars all over her hands, and she was obviously a young girl, and I much prefer to try to treat those with other ways that won't potentially leave scarring. Does that make sense? Any other questions? I will today anyway, in my next appointment or lecture, I will try to kind of emphasize a little bit better what I would like, because I know sometimes there's a lot of fluff in there, and I don't want you to waste time. You know, I do not believe in spoon feeding. You know, we need to be able to figure out what to study, but I do understand there can be a lot of fluff, and so I will try to point things out better. Okay, so we're going to talk about diseases of the hair. We basically have cyclical phases of every hair on our head is in one phase or another. And I'd like you to kind of know these phases. That, not necessarily how long you're in that phase, but kind of what it means. The anagen phase is actually growing, when the hair is growing, and they're in that phase for about 3 years, and that's the biggest majority of the numbers of hairs on our head are in this phase. Catagen hairs kind of going from transition from that growing phase to the resting phase. The resting phase is telogen hairs. These are just hairs that are just kind of sitting there, but they are destined to fall out, all right, over a period of time. It's normal for all of us to lose about 100 to 150 hairs a day. That's just normal. Sometimes more than that if we don't wash our hair every single day. So I think sometimes, you know, talking realistic to our patients about, you know, we're all going to lose some hair. And I will tell you, hair is a big, big deal, especially in gals. I get more tears, or I have gotten more tears over hair-related things than skin cancers. I kid you not. And sometimes these gals have just 3 times more hair than I do, and I'm just like, okay, what's the problem? I'm not seeing any problem here. But to them, I suppose, if you can't belittle. All right, so several things you want to ask about when you have somebody coming in complaining of hair loss. Is it kind of a slow thinning, or is it a shedding? Okay, shedding is when you losing handfuls at a time. Might ask about their hair care products. That's gonna be more with kind of breakage. We're not gonna really talk about things like that. Prescription and non-prescription medications, that's very important. You need to know if there are scalp symptoms associated with the hair loss. Is there pain, itching, burning? And is there any relationship with that when you use certain products, or is it just pretty much all the time? Other body hair, you know, if they're losing hair, are they losing hair on other parts of the body? Or is it just the scalp or wherever? Nail abnormalities, we're going to find out that there are several nail changes that can occur, some of them associated with hair problems. Yeah, in women, you want to look for androgen, you know, or virilization, androgen excess. You know, if you see, sometimes gals who have that will have also really bad acne, especially down in this lower half of the face. They may have more facial hair, or they, you know, do you have to shave every day or every other day, or they'll, you know, bring that up. Lower voice, irregular menstrual bleeding, things like that are signs of potential androgen excess. History of other autoimmune disorders, any recent chronic illnesses, surgical procedures, high fever, you know, things like that. Pregnancies. Have you recently been pregnant? Those questions can kind of help us narrow down what kind of hair loss. So alopecia is just kind of a generic term for hair loss. And then there are multiple types or patterns of hair loss. All right, physical examination. You have to look at that scalp. See if there's a redness, scaling, little hair follicles that are infected, evidence of scarring. Evidence of scarring is going to look more potentially lighter in color, thinner maybe, more shiny, and you won't see as easily or at all the hair follicles or those hair openings, right? Those are the, sometimes it can be real tricky, hard to tell if there's actually scarring going on or not, especially kind of early in the process. So those are some things you want to look for. Is there new hair growth? Pull test. We're going to talk about what a pull test is and how to perform that. Again, if there's hair loss on the scalp, is there hair loss anywhere else on the body? And again, look at the nails. Okay, we basically categorize hair loss into two patterns, non-cicatricial and cicatricial. Those two words are big words just meaning scarring. So non-scarring forms of hair loss and scarring forms of hair loss. And we're going to talk about all of these patterns. All right, so we're going to first talk about our non-cicatricial, non-scarring. Alopecia areata, have you heard of it? No? Okay, some of us. Okay, alopecia areata is where you have very rapid, almost complete hair loss, usually in an annular area, usually on the scalp, but it can be anywhere where hair is. I've seen it on a man in the beard. I've seen it in the eyelash, in the eyebrow, eyelash, arms, legs, places like that. Typically, young adults and children, you're going to see this the most. Etiology is unknown for sure, but it's really an autoimmune sort of thing. They don't know exactly what type of autoimmune reaction is going on, but for some reason, the body is fighting itself, and in this case, its own hair follicles. And you get an inflammatory reaction going on at the base of that hair follicle, and makes it to fall out temporarily. Usually this is asymptomatic. I hear all the time, boy, I was just brushing my hair and all of a sudden I saw this just bald spot. Just freaked me out. Okay, they have also alopecia totalis, is when you have the entire scalp involved. You lose all your hair on top of your scalp. And then there is alopecia universalis, when you lose hair all over the body. Okay. When you look at the scalp, there's not going to be any signs of inflammation. It's just going to look like normal scalp, but a bald patch of no hair. And it's like cue ball smooth, I mean, usually. Yeah,
When it says associated with higher incidence of AD, what's AD?
atopic dermatitis, thank you.
Okay.
Yes, I skipped over that. Atopics are a little bit more prone to having this, don't really know why, but that is, what else did I say? Atopics and obvious other, Down syndrome and other autoimmune diseases. Okay, one thing I for sure want you to know the pattern, be able to, if I give you a description of this, know what alopecia areata is going to look like. I think a good thing to know is this exclamation point hairs. That's just kind of one of those words that you hear. This is when you have hairs that are broken off kind of low. I think it's hard to actually see, but it's kind of, the hair is kind of tapered down at the proximal end, so it looks kind of like an exclamation point. I would not expect you to be able to see that in a picture, but just know that exclamation point hairs are a finding that you can see with alopecia areata. And if you're going to see it, it tends to be more around the outer margin of where that hair loss is. This is one of those hair conditions that can have nail changes. Nail pitting can occur with this, and I think it's like up to 50%. I don't know if I have seen it to those numbers, but it's possible. So you might know that nail pitting changes can be associated with alopecia. Or what other part of the body do you want to make sure you examine when you have somebody coming in? Things like that. When you have just like one or two spots, these oftentimes will resolve on their own. Oftentimes we will go ahead and treat these just to get the ball rolling a little faster, because they usually would like that. When you have really widespread, you know, the totalis, or for sure the universalis, that is challenging and very, very difficult. The main thing you're going to use with these are those three things. Topical high-potency steroids, you know, off and on, intermittent use of that. Intralesional, I will mainly do that. You're going to get a better, faster response with the intralesional versus the topical, but if you're dealing with a younger child that doesn't want needles stuck in their head, then I think that's a completely reasonable approach. And usually when you are injecting, say here's your patch of alopecia, usually you're doing, you know, about a centimeter apart, and injecting just a little bit of the usually 10 milligram per cc. I guess I didn't put that on, but that's usually what we use. Topical minoxidil, and if I didn't put it on there, really we are recommending topical minoxidil for all types of hair loss. Minoxidil is primarily, if you use it by itself, its really main indication is for the androgen-related hair loss, the male pattern or female pattern hair loss. But we're starting to see that it can be helpful in conjunction with your other treatments for all types of hair loss. So don't discourage a person from using minoxidil. Another thing I always mention is women. This is just an over-the-counter product. I think it comes in a solution or a foam base. There's two different strengths, one for men, which is stronger. Women can use that strength too. It's completely fine. I just emphasize that they don't let it drip down their face, because they could get hair growth there, which they wouldn't be happy. Okay. There are some more recent studies that giving a daily oral antihistamine such as Zyrtec may be helpful. They think that somehow down-regulates the immune system, that inflammatory reaction. These types of treatments I might like you to be aware of their, at least the anthralin, the squaric acid, DNCB, and DCP. Put DCP beside that diphencyclone or whatever. It's the same stuff that we used for the warts. Again, the anthralin is kind of a, and I'm not going to test you on what is anthralin, but you might just know that it's an option. You guys, unless if you work in dermatology, probably aren't going to jump into that. You're going to refer on to a dermatologist to do that. But I'd just like you to be aware of the treatment options. Topical anthralin is kind of a tar-based something topical that we kind of use in psoriasis, or used to use in psoriasis. Again, that one and the immunotherapy products, I don't really know how these work. But the anthralin is meant to kind of cause a contact irritant, not a true allergic reaction, but just kind of get some irritation. And the way my feeble brain works is for both of those, it's almost like if you're getting a different type of reaction, immune reaction, maybe somehow it can lower that other immune reaction that's there causing the hair to fall out. That's purely basic in my brain, but that's how I think of it. But again, we don't really know. Just FYI, they have they're doing a lot of studies on some of these other medications. There's a Janus kinase inhibitor that's in studies. They're even looking at some of the biologic medications, the injectable medications that we give for psoriasis. So there's more to come for this. I'm hoping that right now we don't have a whole heck of a lot to offer them, but I'm hoping in the future that we will. Another FYI, that is the National Alopecia Areata Foundation. You might give your patients. Another thing is my previous supervising physician, Dr. Renee Graw at Saints Dermatology, hosts a alopecia areata support group, I think quarterly or something like that. So you might just keep that in the back of your brain. All right, so on the left you see that round, almost cue ball smooth, no redness, no scaling, no nothing except the hair loss. And then the gentleman on the right, he has complete hair loss. I can't see eyebrows there, so it's kind of hard to say, is he alopecia totalis or is he universalis, all widespread? Guys are kind of lucky. I mean, guys go around bald-headed, not too many gals go around bald-headed, so these young kids, I've seen some young kids, and it breaks your heart, because that's just, you know, they have to get wigs or do something. Okay, any questions about alopecia areata? Okay. Androgenetic alopecia. This is the most common type of human hair loss. This is your male pattern and female pattern. I feel like there's probably a genetic predisposition, and the fact that androgen is just there's certain hair follicles that are just in tune more with androgen. Such as, you know, that's why men grow beards here, up here, chest and back, places like that where they can grow hair. So those are areas or hair follicles that can be more influenced by androgen. They feel like that 5-alpha dihydroxytestosterone, DHT, is the principal agent. They found that scalp biopsies of scalps that have balding have a lot more of this, as well as more of those androgen receptors. So you might just know that DHT is kind of the main driving chemical that's associated with it, but for sure androgen. All right, men and women can get this. Men early as his 20s or 30s. My husband suffers from this. He's pretty much balled up on top, but he tries to blame me for that. And I'm like, you know what, you were doing this well before I came in the picture, so you can't blame me on that. Females, usually older, but it can start as early as the teens. It's characterized under the microscope where the hair follicle miniaturizes. It just gets smaller in size. That anagen, that growth phase, is shortened, and you have more of those anagen hairs going into the telogen phase where they would fall out, and you tend to get just these finer baby vellus hairs in a characteristic distribution. So the gender-specific distributions, similar. Men tend to have a little bit more of that supratemporal thinning here and the crown, and it kind of goes together. Gal just is kind of all up on top there, with less so of the temporal. Now, a man can go completely bald. A woman will never go completely bald, but she can get pretty darn thin. And I have to say too, this Hamilton, Norwood, Ludwig classification scales, my next door neighbor is that Dr. Norwood. He was kind of interesting. He is a retired dermatologist, and kind of small, it gets to be a small world the older I get. I actually went to high school with his daughter. My husband and I both did. She went to grade school with my husband, I guess was his first little girlfriend or whatever. And so anyway, Dr. Norwood, our first house we bought, it was his second wife, it was her house, and we ended up buying from her. Then we bought a lot and built, a couple of years ago, and lo and behold, he's our next door neighbor. Nice guy, but it's just funny story. But he was well known nationally for, he did hair transplants, that was kind of his big thing, and was very involved with hair loss. Okay, back to androgenic alopecia. So again, when we look at the scalp of this pattern of hair loss, that scalp is normal. There's no inflammation, you're just going to know. And this is a kind of a very slow onset, okay? The alopecia areata usually comes on quite quickly. This is very slow to present itself. Again, you want to look for virilization in a woman. If you do, or you're kind of suspicious if she has really heavy acne, or for sure a lot of coarse hair growth down here, or hirsutism, have you heard of that term? Okay, good. I would consider doing a little bit more blood work. Free and total testosterone, and when you're doing that, they have a category for men or females. So you want to make sure you order the correct one. I think with any type of hair loss, you may want to consider checking a TSH, free T4, CBC iron profile, just to rule out other forms of hair loss. And I think too, even if you have something that may kind of resolve on its own, I think if you're kind of slightly anemic, your body's going to have a harder time recovering from that hair loss when it's also dealing with low iron. So you could, supplement with iron. It may help the hair indirectly. Okay. Again, don't be afraid to biopsy, because sometimes it's hard to tell. Your history will oftentimes give you a lot, but if by looking at the patient you just can't quite tell, we can always biopsy, either referring on for a biopsy. Usually with that, we'll get in a good representative area of the scalp and do a 3 or 4 millimeter punch, and they will look at that. Treatment. There are only 2 FDA-approved treatment options for men: the topical minoxidil, or the Rogaine, and finasteride, okay, or Propecia. And I don't really care if you know how minoxidil works, but it's supposed to help keep those cells down there by the base of the hair healthier, and prolongs that anagen phase, and helps to make those hair follicles thicker. The finasteride, you may have to know with Dr. Latassi that works on 5-alpha reductase inhibitor, I'm not sure. Has she talked to you about this medicine? No, okay, she might. They do have, just FYI, I'm not gonna test you on this, Propecia itself comes as a 1 milligram daily. But it's very, very expensive. So sometimes I will write for finasteride 5 milligram that they give for benign prostate hypertension, or not hypertension, but hyperplasia. And I will have them take a half a pill. It's more of a dosage than 1 milligram, but they don't feel like it's worrisome for them to take more than that. It helps to maintain what you got. Some people will actually see some regrowth, so they're pretty ecstatic if they see that. I think the general rule though, if they've been on it for a year and they have not, they're still losing hair and they're not seeing any improvement, then just quit it because they're not going to by that time. Hair transplant is always an option. Okay, women. There is really only one FDA-approved medication for this pattern of hair loss in a woman, and that is the topical minoxidil. There are several other medications that we use off-label. Finasteride, some people will use the finasteride like we did in the men. It's not approved for the use in women, and its efficacy is still controversial. I have used it in combination with spironolactone. To me, I'm going to probably add, I have used the spironolactone by far the most. I probably would like you to know a little bit more about that particular drug. It has mild, it kind of blocks those androgen receptors. I probably 150 to 200 milligrams a day is what I push for. I use this in adult female pattern acne. Down here, I don't always need it as high as 200 milligrams, but I feel like with the hair problems that it requires more. So again, this is not FDA approved. You have to talk to your patient and say, you know, we have this option. It's not FDA approved. We're doing this off-label. I think it's always good to inform your patient when you're doing things like that. A couple of things is this can cause hyperkalemia, increased potassium levels. So you want to, it's not indicated for those that have renal disease, hyperkalemia, pregnancy. Again, if you are blocking those androgen receptors and you happen to be carrying a male fetus, you're going to feminize that fetus. So some people say for me to prescribe this medication, you have to be on birth control or doing something. I'm not usually that rigid, but boy, I emphasize to them, this is not good with pregnancy, and I, get that in my note, that I explain this and they understand the rest they're taking. I did have one gal, I wanted to throw up. She was an older gal. She was like my age, I think, or maybe not quite my age, but she was telling me I cannot get pregnant. My husband and I have, tried for years and years and years, and we did in vitro, blah, 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 ends up pregnant. I'm just like, oh my God. But and to be honest with you, I don't know whatever happened because she was moving to Tulsa, but things like that just kind of make you sick to your stomach. These others, I have never really used, so I'm not going to, you might just be familiar with the names, but I'm not going to ask you that much about them. One thing I did learn is cimetidine. I learned that while I was preparing for this, that in higher dosages of cimetidine, it does have kind of an anti-androgen effect. So 300 milligrams 5 times a day they used in the studies and saw some mild improvement. So that's something you could offer. Flutamide, I have never used that, but I went to a lecture and she said that was kind of her first line. The thing you have to be careful with that is that it does have hepatotoxicity, so you really have to monitor that liver closely. These are options, again, off-label or in studies for that for maybe both. I'm not gonna test you on these, this was just kind of a FYI for future. Avodart blocks both type 1 and type 2, 5-alpha hydroxy. This other one, Floridel, I think it's a topical if I remember correctly. It's a topical anti-androgen that's in clinical studies, which I would love if they could come up with something like that for androgen-induced acne, because we don't have anything like that. There is a low-level light therapy laser, Hair Max laser comb, that I guess is an option. I think they probably saw small improvements. I don't know if it's, night and day. And then there's another one that they are studying. Again, I'm not going to test you over those. That's just for your FYI for in the future when you're out working. Telogen effluvium. I remember first time I heard this, I wanted to, God bless the person, because I thought they sneezed or something. Telogen effluvium. This is when you have that excessive shedding. This is due to a stressor. The body goes through a stressor. Your body kind of shifts some of those hairs that are in the anagen phase kind of prematurely into the telogen phase, so you can lose large amounts of hair. Women freak out about this. I experienced this after I had my daughter. I was just like, my God, I'm just shedding my, when you wash your hair, the shower drain was just covered with hair. And typically you have very widespread involvement. It's not going to be just up here, that sort of thing. Females way, way, way more commonly will struggle with this. So what are some of the stressors? Some of the big stressors: hyperthyroid, hypo or hyperthyroid, postpartum, stopping birth control pills. Those three I want you to know. Any rapid weight loss, say a person has some kind of stomach stapling or something like that, and their diet, protein intake really drastically changes, that may encourage that. Iron deficiency, physical stressors, your high fever, febrile illness, malignancy, chronic infections, major surgery, major trauma, psychological stress too. Don't worry about the intoxication with thallium, mercury, or arsenic. Drugs, I'm not going to really hold you responsible for those except the oral contraceptives, because that's the one you're going to see the most. But again, you might, if you're hearing of a person with what sounds like telogen effluvium, you're going to always ask them about their medications, so you might keep that list handy and see if they're on. Okay, so once again, no inflammatory changes noted to the scalp. It's just a completely normal looking scalp. You're going to have diffuse thinning, especially kind of to this temporal area. Bag sign. This is when, and this will happen, women will come in with bags of hair that they have collected. This was 3 days ago, what came out when I brushed my hair 3 days ago. This was 2 days ago. This was yesterday. They will bring bags in. So, you can tell it's really bothering. This is when you're going to do the pull test. And the pull test is when you take a small, I can't grab yours very well, just take a small grouping of about 40 hairs, and then you just kind of pull it through your fingers and see if any come out. Typically, none or maybe one will come out with each time you do that, but if you're pulling out 3 to 6 hairs every time, that's positive, all right, and that indicates that shedding process, all right. So you might know that that's associated with, a test to check for shedding or telogen effluvium and things like that. Again, sometimes that stimulus that causes the hair to do this, you can also affect the growth of the nails. We'll talk about that. There's something called Bowes lines that we will talk about. If, again, you have you're just not quite sure if this is telogen effluvium, or if it's a female pattern hair loss, or what, you can always biopsy. One thing they can look at under the microscope is it will be able to tell if the ratio of telogen to anagen hair, excuse me, hairs is appropriate, and if the telogen hairs are in a higher ratio than normal, then you can help to get your diagnosis. Again, you can always get blood work just to make sure that we're not really, make sure that there's not hypothyroid or hypothyroid that we need to treat. Okay, if you can treat or treat the primary reason why that hair is falling out, do so. Most of the time you can't. I think just, again, topical minoxidil, that's not a cure-all, but I think it can, again, encourage that hair to grow back a little bit faster. Just try to reassure them that the rule is that all their hair will grow back. All right, it just, the hair grows very slowly. Typically what happens is the hair will start falling out several months after, say a woman has her baby. The hair won't usually start falling out for 3 to 6 months later. And so it's hard for her to connect the two. So then you'll go through a month or two of just shedding, and then it'll kind of start slowing down, and then it'll go back to its normal self. So again, they're pretty panicky about this. If you can just, let's get some blood work, make sure there's nothing else going on. I think that's what this is, and it should completely take care of itself, reverse on its own. That's what they need. This can reoccur in people. People who tend to have this condition will tend to have it more times than once. And I do think that there are some people who kind of get into a chronic pattern of this. Okay, let's talk about our scarring alopecias. All right, so this is due to significant amounts of inflammation in the scalp that then destroys that hair follicle. And it lays down fibrous scar tissue, and it permanently does not allow that hair to grow back. All right, so big difference between these non-scarring and these scarring processes. This is usually not an infectious process going on. It's more of an inflammatory process. Broadly categorize these inflammatory as kind of what type of cell is infiltrating the scalp. Is oftentimes lymphocytes or neutrophils or mixed. I don't care about that. I'm just telling you about that. You don't have to know which is which types of hair loss are lymphocytic or neutrophilic. All right, so it does replace fibrous scar tissue, which is permanent. All right, again, the lymphoid-mediated disorders and the neutrophil-mediated disorders, I don't care if you know which is which. We're just going to talk about them. So discoid lupus. I'm going to see this a heck of a lot more in the female population. Younger adult, 20 to 40 years old. The thing, discoid lupus is usually always just associated with the skin, lupus in the skin. However, in about 5 to 10%, they can also have or develop systemic lupus. So if you see discoid lupus or you diagnose discoid lupus, you are going to evaluate for systemic. You don't want to assume that it's only in the skin. So this is where you just have one or more red, atrophic signs of scarring, areas of alopecia. Sometimes, especially in discoid lupus, you can have kind of a hyperpigmentation and or hypopigmentation within that plaque. Sometimes it can be kind of sensitive or itchy. Oftentimes you're going to hear these more inflammatory scarring processes are a lot more symptomatic than the non-cicatricial. One thing that I do want you to know for sure is that any lupus, discoid included, is very driven by sun exposure. So they may report that these came out after they've been at their kids' baseball game or all-day soccer tournaments or on vacation in Florida or whatever. So you really need to pay attention to that, and you're gonna really encourage them sun avoidance. Other parts of the body, oftentimes when you have DLE of the scalp, you can have it other areas of the body, such as the face. Big places I want you to look for is on the ear and the conchal bowl. Very commonly you will have lesions there as well as on the scalp. All right, so we're always going to check for systemic lupus with an ANA. Biopsy, you're going to hear me say this every time. If you are suspicious of scarring changes, biopsy or refer to get biopsy. Because again, sometimes it can be kind of tricky to see those scarring changes. Management of this, class 1 or 2 topical steroids, high potency steroids, probably even more so interlesional Kenalog injections, just to, as quickly as we can, calm this inflammatory process down, because the faster we can calm that down, hopefully the less scarring will result. That's our goal right there. Now with this one, it's not uncommon. Any of those lupus type of disorders sometimes need a medication. Hydroxychloroquine is the drug of choice, probably especially in the summer months. I will see these people with discoid lupus of the scalp or really anywhere will always have flares in the summer months, and we will oftentimes at least get them on that hydroxychloroquine during the summer months and then maybe off in the winter months. But emphasize that sun protection. And there are some examples. You can see where that looks, you know, a little bit more hypopigmented in the middle and hyperpigmented around the edge. There she's got lesions on the ear and that conchal bowl. That looks pretty. Now with that one, it's a little hard to see the true scarring changes of the scalp. You know, I used to have a little dermatoscope where I could magnify and see things better, and it really does help. But okay, lichen planopilaris. Have you guys had lecture on LP, lichen planus? Okay, so this is a scalp version of LP. Sometimes people will have other skin-associated cutaneous rash, sometimes, or in the mouth, the Wickham striae in the mouth. Sometimes you will not find any of that. Middle-aged women is where you're going to see this most often. Again, sometimes, remember when I was talking about drug reactions, that there are certain drugs that can mimic other rashes like lichen planus. This is one. Sometimes you can get a lichenoid drug reaction. Those are the more common medications. I'm not going to test you on that. I just want you to keep that in the back of your head. Usually starts at the crown or the vertex and moves forward, itching, burning, sensitivity. These people are going to experience that. There is going to be redness, especially around those hair follicles. Sometimes you can get kind of a scale accumulation around those hair follicles as well, and usually the scarring changes. There is a variant of this that I'd like you to be aware of called frontal fibrosing alopecia. And this is a variant of lichen planopilaris seen more in older women where they have a pad or a band up to the frontal scalp or scalp and forehead, temporal frontal alopecia. Oftentimes they will lose their eyebrows as well. I had a gal, this was the weirdest thing, I had a gal not too horribly long ago who, I mean, she had obvious scarring changes to me, looked just like this, got a biopsy, and it came back as tinea, fungus. I'm like, what? It's one of those where you're like, what you see clinically and what you get under the microscope are, they don't coincide, and so I said, this doesn't look like this, but we'll go ahead and treat you, bring you back. She was maybe a smidge better, but not, some of the scale I think was a little bit better. So then we got her treated more appropriately. It was just like, I wasn't expecting that out. Okay, again, always biopsy if you consider that there is some scarring process. Management, you kind of see too, management with a lot of these scarring alopecias are pretty much the same. Topical steroids, potent topical steroids, intralesional Kenalog. Usually you're gonna inject those every 6 to 8 weeks, 4 to 8 weeks, something like that. Sometimes you will need some of these other systemic medications, and you may use oral steroids as a bridge, say kind of get them on oral steroids to get the inflammation calmed down, knowing that a lot of these other medications kind of take a few months to kind of really get rolling, so kind of bridge those two. I'm not going to test you on those other systemic medications. So there, as you can see, that perifollicular erythema. Here you can appreciate better, I think, what it looks like, true scarring on there. It looks a little bit more shiny, smooth. You really cannot appreciate any of those little hair follicles, hair openings. And that front is textbook for that frontal fibrosing alopecia. Now that one almost looks like it's burned out. I don't see a lot of redness and inflammation, so it may have already kind of passed and done its damage. Again, these cicatricial alopecias, the main goal is to calm that inflammation down, that inflammatory process down, again, so that we can minimize how much scarring. Once we get all kinds of scarring, there's nothing we can do. All right, central centrifugal cicatricial alopecia, big glowing, CCCA. This you're going to see a lot more in the African American population. It's been called the hot comb alopecia because they felt a while back that it was only seen in black women who used oil and hot combs to straighten their hair. They still do that. They don't do that as much. They use more chemical relaxers. So we don't feel like it's strictly that, but we still feel like there's some kind of a traumatic chemical traction, some kind of an irritation going on that's getting that inflammatory reaction going. Again, vertex and slowly moves forward. With this one, you don't get as much redness and inflammation. You're just going to see some scarring, skin-colored patches of scarring alopecia. And that centrifugal means it starts here and spreads out. That's what that word means. Possible polytrichia. I want you to be familiar with that term. There's three terms that pretty much mean the same thing. Polytrichia, doll's hairs, and something else that's a little bit down the road. I'll bring it to your attention. That is what you see oftentimes in these inflammatory conditions where you get like a number of hair follicles or hair strands coming out of the same follicle. Okay, it just pushes, all that inflammation pushes those hair together. And look, you know how dolls you get, they have this big hole with like 25 hairs coming out of it? That's what this looks like. Again, biopsy if you're not sure what it is or if you think there's scarring. Really try to discuss with these people how they're processing their hair. Reduction of traction. I know African Americans oftentimes, well, they call their relaxation a perm, where for us it's curling our hair, for them it's relaxing with the curl in their hair. They sometimes will heat cornrows, a lot of tight braids, things like that can encourage this sort of stuff. So again, strong topical steroids, intralesional Kenalog. With this one, I will use a little bit more of your doxycycline, more of an anti-inflammatory rather than, it's not a bacterial thing, but we'll use it sometimes with as an anti-inflammatory medication. Again, other systemic meds more than likely will be needed. You will probably be referring these people on. And that is what that looks like. And some poor women come in with like very little hair left, and you're just like, darn it, I wish you'd come in 10 years ago and we could have, you know, saved some of that hair, but at that, you know, when it's so far beyond, there's just not much we can do. Okay, folliculitis decumbens. Your young and middle-aged adults, especially more males, I see a lot more males than I do females. This is when we get neutrophils invading the scalp. A vertex working itself forward. This one you get follicular pustules and follicular hyperkeratosis, or almost a collection of scale around the base of those hair follicles. Get tufted folliculitis, that's the other term I was trying to think of, when you have these bunches of hairs all grouped together. We are not really sure. We know that, you know, if you swabbed their scalp, those pustules, more than likely there's going to be staph there. We don't feel that this is just strictly an infectious process, but rather that in some people, they just get an overabundant reaction to that staph there, okay? So it's a abnormal suppurative immune response to that staph or other organism, okay? I'm just about done, and we'll go for a break. Pain, itching, burning, management. Unfortunately, there's no quick fix for this. You pretty much have to maintain them on at least intermittent, long-term antibiotics. I usually will use kind of a combination of the top four. At least get things calmed down faster with oral antibiotics, topical antibiotics for more maintenance, topical steroids, because they oftentimes will complain of itching, and that at least will help calm some of the inflammation down. Now, I do recommend that they don't, you know, use this every day for the rest of their life, but use it more when there's itching involved. You can use Accutane or that oral isotretinoin. It can sometimes have a little longer term remission, but it's never going to be a cure. See, that's a good. See how all those tufted folliculitis or those hairs all bunched together? Dissecting cellulitis. There is a follicular effusion triad that includes acne conglobata, hidradenitis suppurativa, and this dissecting cellulitis. You might be familiar with that. Dissecting cellulitis can present all by itself without the other two, though. Young men, 18 to 40 years of age, much more so in the African American male. Not really sure. We know that they get follicular occlusion, blocked with keratin. That hair follicle then kind of ruptures and you get this big inflammatory reaction. This you're going to get red pustules, but these develop into these deep, boggy, tender nodules that are just full of pus. This is pretty yucko. Abscess formation, sometimes they'll even form these sinuses where you inject here, but it'll start, you know, draining from 3 inches away. Suppurative, so suppurative means it develops pus, and you get this purulent drainage and crusting. This is just very, very uncomfortable. Sometimes, obviously, with that much inflammation, you can lead to scarring. African American population is always very prone to keloiding, so it's not uncommon to get real thickened scarring with that too. Management is tough. Pretty much the same as before. Oral antibiotics, topical steroids, interlesional to help into those, you know, big boggy areas. Again, oral isotretinoin can have a prolonged remission, but it's not my first, you know, go-to. Sometimes we'll IND, but usually not. And then talked about excision with skin grafting, but that's going to be sent on to somebody else. Okay, let's go. Oh, here, and that's what it looks like. You'd be surprised. I had this one young, he was probably 16, 18 years old and had that horrible, and he was so uncomfortable. And we put him on, I put him on Accutane after we tried